Professor Jason Trubiano, Dr. Geoff Mackay and Dr. Sam Thorburn to talk to us about all things allergy. Now, before we begin, I would like to acknowledge that our presenters in Melbourne are presenting on the lands of the Wurundjeri people of the Kulin Nation and pay my respects to their elders past, present and emerging, as well as any Aboriginal and Torres Strait Islander people on the call today. We should note that today's session will be recorded and available on NCAS after the session. And if you have any questions, pop them in the Q&A section at the bottom of the screen, and we'll be able to pass them on in our discussion session at the end of the talks. Now, I'll introduce everyone before they give the talk. We're going to start with Professor Jason Trubiano, and it's not every day that you get to introduce your boss, so I'm excited. Professor Trubiano is the Director of Department Infectious Diseases and Immunology at Austin Health, Head of the Drug and Antibiotic Allergy Service and Head of the Department of Infectious Diseases at the Doherty, University of Melbourne. Congratulations, Professor Trubiano. He also leads the Centre of Antibiotic Allergy and Research, which really needs no introduction as it continues to define how we address antibiotic allergies in large clinical trials and interventional studies. And his point of care decision tools, PenFast, Solfast, KefFast, continue to define how we address allergy clinically as ID physicians. We are delighted to have Jason here today to talk to us about peri-operative antibiotic testing and the PREPARE trial. Take it away, boss.
Thanks, Gemma. If you called me Professor Trubiano one more time, I thought I was going to lose it. But I will just do the obligatory screen share, everybody, and presume that you can see those unless I hear otherwise. What I was going to do today was talk about the PREPARE trial. And the PREPARE trial was one of the pilot feasibility trials that we did regarding delivering antibiotic allergy assessment and challenge in the perioperative period. But I've got a small number of slides because I thought what I'd do is actually give you the true insight into this trial, because we get a lot of questions about implementing penicillin allergy testing and the perioperative testing, and I'll give you the headline statement. It's not all it's cracked up to be, and it's actually quite a difficult task. Not unsurmountable, but definitely needs more work. So what I thought I'd start with initially is barriers and enablers and why we even thought about doing this in the first place. And I think it's good to, before you deploy a trial, think, well, actually, do we have enough enablers to make this happen? And so from a trial perspective, this was actually designed and set before we even had PenFast. We wrote the protocol pre-PenFast, and at that time we were using the antibiotic allergy assessment tool. And for those that haven't seen this before, most on the call would have traffic light system, low being green, moderate being orange, red being red, and green being go and challenge them, white they don't even have a allergy label, please directly delabel them. And this was actually how we started up all our inpatient programs. It's actually how we deployed a lot of our whole of hospital programs, because whilst we love PenFast, you need to be able to ascertain a history. And so we still use this tool in conjunction with PenFast, taking the history, giving us the information we need to plug into a 3-point clinical decision rule. And so we thought, when we're deploying this in the perioperative setting to non-allergists, and this setting anaesthetists, we would go with this tool. It had high sensitivity and specificity. It's been adapted in pediatrics and actually is used in a lot of hospital systems, including many hospitals that are part of the Safer Care Victoria rollout, which still use this tool today. Obviously, PenFast was used in this randomized control trial, but the PALACE study was actually nothing to do with PenFast, really. We did PenFast to assign people a low-risk criteria. It was designed to show that direct oral challenge was non-inferior to traditional skin testing. And we're really proud of this paper still, and Anna did an amazing job leading it. It really defined that direct oral challenge is non-inferior. It was safe in the 1-day follow-up, the 5-day follow-up. And when Anna published the 6-month follow-up in JAMA Network Open, it also demonstrated safety. And I think this has been something that's been able to change practice and allowed us to say, well, we could do direct oral challenge in low-risk people. And this is what the second point of the enablers was, direct oral challenge, or DOC safety. Now, the third was, well, does anybody care about doing this in the perioperative setting? And interestingly, when you talk to surgeons, they are most fearful about surgical site infections. There's a reputational risk, they're proud of their work, and if you tell them that actually they're giving a drug that is inferior, that is more likely to cause a surgical site infection, i.e. clindamycin, that this was a great driver. And so we were already getting a lot of referrals from surgeons to see patients before surgery. So this was a good leverage for us and certainly a good enabler. And we also had lovely evidence, mainly from the US, I have to admit, that demonstrates that if you carry an antibiotic allergy label, you are more likely to have a surgical site infection. Now, I think this data is harder in an Australian setting where our AMS principles are much better and we use far less vancomycin in the operative setting, but still, Clinder and Vanc were definitely associated with this outcome. Okay, so the other one was the great work actually done by a friend in the UK, Neil Powell. He's a pharmacist, and he's done a lot of qualitative work looking at barriers enablers within different non-allergist work groups, including in the anaesthetist group. And from this article, which I highly recommend, it talks about some of the enablers. And the anaesthetists clearly understood that giving cefazolin or penicillin led to better clinical outcomes. And there were strong beliefs that they could also do this, that it was in their wheelhouse to be able to assess patients for their allergy and also do penicillin allergy delabelling. But there are barriers, and in the same article, it actually talked about those barriers in the anaesthetic group. And one of them was, well, I could do it, but what's the reward for me? You know, what do I get out of this, doing all this work before they go into surgery? Will that be believed by the surgeon when they get wheeled in? And that was interesting to come out. That hadn't really come out in other craft group work that we'd done or we'd seen done before. So the other thing was, well, is it even feasible? Like, can we actually go and do this in the peri-operative clinic? And I think we did have some observational data only, but certainly no prospective randomized data that demonstrated that it was safe. So this brought us a step back. We couldn't go to a phase 3 effectiveness trial because we didn't even know if it really was safe to be able to be done. So that's how we got there. So we wrote this pre-COVID, the protocol. It was rolled out COVID and then finished afterwards. It was a pilot feasibility and safety randomized control trial where we were really looking at, can we recruit people into this trial, get numbers? Was it safe to do? And these were the key principles and our primary outcomes. And it was done at 3 hospitals, Austin Hospital, Royal Melbourne Hospital, and Alfred Hospital. And it was the investigator group, as you can see from that list, was a great list of ID physicians, surgeons, and anaesthetists, particularly the anaesthetists that had a peri-operative focus. So the study overview in the traditional format, it was the population was peri-operative patients that had a reported beta-lactam allergy that were coming to pre-assessment clinic. Already we've got a slight selection bias. We're not seeing everybody that goes and has surgery. We're seeing those that were going to a pre-assessment, so they're likely to have more comorbidities and therefore maybe more likely to benefit from this rather than a very well 18-year-old that's going for their shoulder to be replaced or surgery. The intervention was a smartphone antibiotic allergy assessment, and I'll talk about that intervention a little bit more in detail. The other one was the comparator was standard of care. We did nothing. We let the anaesthetist do whatever they would normally do in peri-operative clinic for somebody that reported an allergy. And as mentioned, the outcome was safety and feasibility. If we look at some of these points here, timeline, I mentioned December 2020 to 23. This was done as part of Joe DeLuca's primary paper in his concurrent PhD. We pre-published the protocol before starting the trial. The inclusion criteria was pretty clear. It wasn't overly complicated. Adults, outpatients, where they had a beta-lactam allergy, and they had a surgery where we thought they were going to require antibiotic therapy. It was one-to-one randomization, computed block, nothing really fancy about the randomization process. So this is the back end. This is why it took so long. The algorithm, and a lot of people on the call here obviously do a lot with decision support, but this was the algorithm that was built by our app designer. It really took the antibiotic allergy assessment tool and converted that to a digital app where it then spat out an output of risk, low, moderate, and severe. And this was being done in a trial setting. And it also talked about the safety of cephalosporins. So in terms of the intervention, this is exactly what it likes, and we'll see if this plays. It is now in this app here. You put the antibiotic in. If you knew the name, great. If you didn't, you would put penicillin unspecified. It then has a drop down in both lay terms and medical description of the allergy phenotype. You could select through what you want there. There was a timing of the reaction. Most we know were unknown. Were they hospitalised? Did they get treatment? And then it would move on to what their risk criteria was. Low risk, and this was based off that assessment tool. So that's how it worked. That's what the anaesthetist would see. So the patient would be recruited and consented to the trial. They would go into the peri-operative assessment, and then a trial nurse or investigator would hand the anaesthetist an iPad and say, this patient has been randomised to this assessment. Please use the app to do the assessment. They would go out of the room and leave the anaesthetist to do the assessment on their own. So they were not guided or didn't have enhanced support by any one of us. So that's the intervention. I think it's key to work. Obviously, though, just to go back on that, this is a trial designed area where we were able to give the app to the anaesthetist. There's a whole workaround that needs to be sorted and done about actually how to make that part of a routine practice. And I'll talk about what we need to do at the end, I think, which is important. But here's the results, and this tells you as well, 511 patients, but only 150 randomised. Why? Because we couldn't get a staff member to every single consult in every room to hand an anaesthetist an iPad. It would have been very resource intensive, and most of them were excluded for that reason, rather than they declined to participate, which was a smaller number. We ended up randomising equal numbers in the enhanced assessment arm, which is the intervention arm, the smartphone app, versus the standard of care. And you can see, though, that in that, those that were assessed, if they were low risk, the 30, the vast majority, 28 of them went on and had the direct oral challenge. The 44 that were assessed as moderate or high risk also went forward and had testing in a significant proportion. We compare that to the control arm. Very few got assessed and very few went on to have testing as part of standard of care. So it wasn't built into the anaesthetist workflow to think about referring these patients for testing before surgery. In terms of a population group, as most unfortunate studies here, we were a white predominant population. We had equal representation of sex. Recruiting sites was predominantly at the Austin, with a smaller number at Royal Melbourne and Alfred. They were comorbid, again, a selection bias because they were coming to pre-assessment clinic. And what I did like is they did have a significant amount of immunocompromise. So like most of our allergy studies, most had immunocompromised status, and most of them were through solid organ transplantation was the highest, and that was again a selection bias because of the Austin Hospital. So here's the primary outcome in terms of feasibility, and I think you could see that already in terms of recruitment. We recruited a number we would have liked more of. We recruited 150 of the 511, and we talked about why they were excluded. So it was feasible to do it, but our recruitment to screening ratio was lower than we would have liked. And I think that's really important to work about what we would need in another study going forward, or an implementation study. The outcomes in terms of safety outcomes is the bottom of this table. What we wanted to look at was not just adverse events to the oral challenge at the time of getting the drug. We actually included adverse events all the way up to 90 days after the surgery. We wanted to see if there was an adverse event in theatre when they got that drug again, if there was an adverse event with other drugs given after. I'm talking about antibiotics only. And what we did see was there was a very low rate of adverse events in the group that underwent the intervention, incredibly low rates in that 1 hour period after the oral challenge, only 2. And we did not delay or impact surgery, which was a key thing we wanted to do. We didn't want people cancelling their surgery because they were waiting for allergy testing, which was very important. So I think the other thing that we did note is that we saw a high correlation of what the anaesthetist assessed and an oral challenge outcome. What would have been a disaster is if the anaesthetist had assessed everybody as low risk, they went forward for testing and we had a high oral challenge rate, or higher than what we'd seen in the previous literature. So I think it was great to see a 2.7% in-clinic oral challenge rate for them getting that direct oral challenge. We did have some exploratory secondary endpoints, and obviously we were super keen on these. And this was looking at antibiotic prescribing in the peri-operative period and the post-operative period. So we did see that there was a reduction it's a very small table, but I'll pull out the key things for you. There was a reduction in clindamycin or vancomycin use in surgical prophylaxis, 17% in the control arm versus 10% in the intervention. We were never powered to look at that. The odds ratio was 0.55, but the CI crossed 1. But I think this was a great opportunity for us to look at a sample size calculation for effectiveness study, but also show a signal that this was going to reduce use. And this is predominantly in the Austin setting where we've almost tabooed clindamycin or vancomycin being used in this setting. So to see it in this setting, I think was encouraging. We also saw an uplift in cefazolin use, obviously, in relation to that. We saw no impact on mortality or surgical site infections, a slight increase in the control group, it was 8.8, I think, in the control group to 7. But again, maybe in a larger study, this would be a different outcome. We also looked at post-operative antibiotic prescribing, and we didn't see much of a change there, except the restricted antibiotics were higher, 14% in the control group versus 7% in the intervention. Again, not powered, an odds ratio of 0.46, and again, it crossed 1. But my takeaway, yeah, look, it probably will increase cefazolin and reduce restricted antibiotic use. And this is in an era where we're searching for novel AMS interventions to reduce or increase surgical prophylaxis efficacy and the right choice of drug. So my takeaways from this is that it's definitely safe. We didn't see any issue with safety. The assessment performed by the anaesthetist using the app correlated with the testing outcome. It's likely to impact prescribing, but we're not powered for that. We didn't make conclusions in the paper about that. And the question to me is if it's actually feasible. I still have questions about feasibility, about buy-in, and about being able to deliver this as a standard of care. So for me, after the study, have we implemented this as practice at the Austin? The answer is no. I actually think it needs more. And so what I think the next step for Prepare is Prepare 2. And we need a type 2 or type 3 hybrid implementation trial. I've written 2 here because I would like to look at co-primary outcomes in this rather than just an implementation outcome. So I would like to look at the effectiveness intervention being this adapted NAN app, but probably have more work in the co-design with the anaesthetist. This wasn't done, it was designed by us, but I'd like to put it now in the anaesthetist's hand. What do they feel about the app, and actually look at like an adapt model with a co-design model. And then I would like to look at the implementation stream being more education. We didn't do an education program as part of this. It was not the design, but clearly if you're going to implement it, we need education, plus or minus audit and feedback to the anaesthetist on the benefit of their intervention. I think that would be interesting to do. And then have co-primary outcomes. I've written this type 2 hybrid implementation trial because we would want to look at the effectiveness outcomes on operative prophylaxis. We've got enough now to power this study for that. And then look at the adoption. Was this adopted by an increasing amount of physicians when we educated them and made it available in the testing centres? So they are the kind of ideas I would think would be central to a hybrid implementation trial. And I think you'd want to leave this in, right? So you'd want to leave it in place. And it'd be great then to have a step wedge format rather than a cluster crossover where this stays in place afterwards. Clearly, this is what we're thinking. And we've had some good discussions about Trish Peel and myself working this through in a peri-operative setting. And I think if people are interested, let us know, because it's something we definitely want to do. And we're looking for sites to enable Prepare 2. So a lot of this study was done by the work of many people on this slide. In particular, I wanted to call out Joe DeLuca, who slaved away at this for his PhD study, our research team, and all the anaesthetists and peri-operative teams at all sites that really were engaged to do it. And hopefully we have some more results in the future with Prepare 2. So thanks very much.
Thanks so much, Jason, and thank you for sharing that awesome trial and its implementation and the insights of the group of where you might take things next. It's exciting to see. I would encourage everyone to pop questions and comments in the chat. We will come back to this at the end of the session. We're going to move to our second speaker and then open for discussion. So with no further ado, I have the pleasure of introducing both Dr. Geoff Mackay and Dr. Sam Thorburn. Geoff is an infectious diseases and antimicrobial stewardship physician at Albury Wodonga Health, where he implemented penicillin allergy delabelling programs, which was one of the first regional programs in Australia. Now, he's really passionate about regional and rural healthcare. He's the principal investigator for INAN in Albury, as well as a faculty member of Check Again with Safer Care Victoria, where he's involved in the education of the regional sites and implementation of those programs. And he's joined by Dr. Sam Thorburn, who's one of our clinical immunology registrars and an ID physician, too many titles, Sam, and was an advanced trainee in Albury Wodonga with Geoff at this time. His areas of interest include antibiotic allergies in underserviced populations, as well as immunocompromised hosts and inborn errors of immunity. So I welcome both of you to present on your implementation strategies in regional Vic.
Thanks very much, Gemma. Also, thank you for the promotion to doctor. It's good that Jason's not the only one being promoted today.
I realised that after I said it. But,
that's all right. So
we're going to let that fly.
I'm an AMS and ID pharmacist at Albury Wodonga Health, everyone. I'm just going to get my slides up. So shout out if you can't see them in a second. All right, we're good to go.
Yeah, they've loaded. Looking good.
Okay, beautiful. All right, well, yeah, thanks everyone for having me. I'm here today to co-present with Sam Thorburn. So as Gemma mentioned, so I work at Albury Wodonga Health, which is a cross-border health service in the northeast of Victoria, or the southeast of New South Wales. And I'm co-presenting with Sam today. Sam joined Albury Wodonga Health as an ID registrar about 6 months after I implemented this program. And he was pretty pivotal in accelerating the progress that we were making and the number of challenges we were conducting. So I'm basically here to talk to you about how we set up our program in regional Australia, and just to give some overview of that. So we're going to cover how we set up our model, what I perceive are actually the advantages of being regional and remote when trying to set up a delabelling program at your health service. There's obviously many disadvantages, but there are some advantages that I think are key. What's been the impact of our procedure and what have I learned? And then Sam's going to give his view on like the registrar experience between working at a regional health service and a metropolitan health service. And then we'll have a consumer story at the end. So as mentioned, Albury's a cross-border regional health service, which makes it quite unique. This has disadvantages as well as advantages. Albury's entirely acute hospital with about 180 beds. Wodonga's a subacute health service, and we have no electronic medical record, which does make it quite difficult to identify patients who have penicillin allergies. So for those of you who've never worked in a paper-based system, the part of the medication chart in which you are sort of given to write a patient's allergies is about the size of a credit card, and it sits right next to the patient ID label section. And this is a really insufficient amount of space to adequately document a patient's allergy to a medication. So at our health service, we use an alert sheet, which is a fairly common practice for paper-based services. Basically, this just sits either in front or behind of the medication chart in the same folder by the patient's bedside. And it just allows us to more accurately document patients' allergies. And there'll usually be a note in the on the medication chart in the allergy box that says "See alert sheet" for patients who have more complicated allergy histories that needed more room to document. So what is the AWH budget model for doing this? So we have no allergy or immunology specialist at AWH. We don't have any dedicated funding to run this program, and we had no dedicated funding to establish it. We do have a decent size ID AMS team for a regional health service. So we've got 2 ID consultants, a full-time ID registrar, and we have 2 AMS pharmacists, of which I work 0.5 FTE. Although when I set this up in Albury, I was only working 0.3 FTE in AMS. So it was set up on 12 hours a week with no funding. So it really can be done with very little paid support, I suppose. So how did this all happen? So just very briefly, in 2019, I became interested in this after listening to lots of Purple Pen podcasts. So Jason was actually on episode 1 and episode 50 talking about antibiotic allergies, and I was just immediately struck by the topic and thought that it was pretty low-hanging fruit, that there's a large benefit to be had with which wouldn't be too difficult to attain. So I always had an interest in this. And then in 2019, my nonna was quite sick with sepsis in an ICU in Griffith, and she received really suboptimal empiric antibiotics for sepsis, and all she had was nausea as a reaction to Augmentin. So once that happened, that really kind of kicked me into gear, and I decided I wanted to do something locally. So in early March 2021, I contacted the Austin, spoke to Jason, and basically said I'd like to do something similar at my health service. And then I developed a procedure for Albury Wodonga Health based on the Austin procedure, which was then reviewed a month later by the Austin, as well as our own specialist at Albury. And within a few months, our AMS subcommittee had approved that procedure, and our local and ethics and local governance paperwork was completed. So all this happened in about 3 months. So Albury became the 3rd site to join the Antibiotic Allergy Discovery and Delabelling program, which was sort of the precursor for INAN. Then we had a huge gap because I had to wait for corporate records to produce the documents that we needed. But less than a year after we sort of started this process, we challenged our first patient. And in October 2022, I was quite proud that Albury was the 2nd site nationally to join NAN. So we got our paperwork in promptly and snuck ahead of Peter Mack. And as of today, we've challenged 52 patients with penicillin via direct oral challenge at Albury Wodonga Health. And we've had 2 patients react to the challenge dose, and 50 patients have no reaction. So what is the typical process at our hospital? So the first challenge is identifying the patient, because we can't run a report that just says this is the 16 patients in your hospital who say they've got a penicillin allergy. So the patients are generally identified by the AMS pharmacist on an AMS round, or the ID registrar during an ID round. We do get quite a lot of referrals now, though, which is really promising, and I wanted to focus on that a little bit later on, because I think this is where our program has kind of evolved to, which is good. So we get a lot of referrals from Surg Reg and Med Regs. So if the allergy label is being assessed by someone who is a member of the research team, we'll use the NAN app. But our Albury Wodonga Health procedure has the antibiotic allergy assessment tool that Jason showed you earlier, that most of you will be familiar with. So we actually assess allergy labels in 2 different ways, and I'll go through that in a bit more detail. So if the patient has a low-risk allergy label, we educate them on the benefits of a challenge, offer them a challenge, and if they want to go ahead, they sign just a general consent form. We used to check in with a bedside nurse every time to make sure they were comfortable, but this doesn't happen too often anymore, because basically every nurse in the hospital has either conducted an oral challenge or has at least sort of seen one happen on their ward. So then we get someone to prescribe penicillin, take a baseline set of OBS, and an hour later, if there's no reaction, we cross off their allergy label. And we do a post-challenge review with the patient where we give them some information, and then I contact the patient's GP and community pharmacy. So I won't go into great detail about this, because most of you know what it is, and we literally had this Austin's version of this document in Jason's slides. But basically, when we do an allergy assessment, the research team members will use the NAN app. We will still fill in the antibiotic allergy assessment tool, though, to fulfill the requirements of our local procedure. But anyone who is not part of the research team, like Surg Regs who want to do a challenge, or Med Regs who would like to do a challenge, they still fill in this antibiotic allergy assessment tool. And as with what Jason was saying, we only really challenge patients that are green or white. We do still do a few white challenges for patients who say they've got diarrhea or vomiting. Sometimes the patients just need the challenge to be convinced rather than to tell them that it's a side effect. But most of our challenges are green. So for those of us in the research team, we use PenFast, which is built into the NAN app, which is a really useful tool and a really useful app. And then what we have is our antibiotic allergy inpatient challenge document, which basically sits with the patient throughout their challenge. And this document just ensures that everything that needs to be ticked off is ticked off before the challenge and then after the challenge. This has become particularly important for us because we're now seeing more and more challenges from people who don't have specific antibiotic allergy training. And this just ensures that all safety measures are in place and that all reporting that needs to be done after the challenge is done. So this has been quite helpful, and so far every challenge we've had outside of the research team, this document has been completed. And finally, this is the document we give the patients if they pass their challenge with no reaction, which basically just says, congratulations, you've not had a reaction. And a severe reaction would have occurred very quickly. However, in rare cases, you may experience a less severe delayed reaction. And if this occurs, this is how you contact us. Both of the patients that we have had that had a reaction to their challenge were actually discharged and had the reaction the following day. And both of them utilised this document to get in contact with our team. So we were able to give them very prompt advice. So the document does work. So the initial research team was just me. And one of my learnings is definitely that that's an inadequate amount of people to do this. So our current research team has 6 trained pharmacists that are all associate investigators. That's really helped me out. And I now have a far greater capacity to send other people if I'm unavailable, if someone needs a bit of assistance working through the procedure. And we have 2 former associate investigators that are ID registrars. I don't sign my ID registrars up anymore to be associate investigators. It's too much paperwork. So what support do we actually have? So as mentioned, no time, no funding really to do this, but I have a very supportive director of pharmacy and a very supportive AMS subcommittee. So whenever I wanted to implement anything or whenever documents were raised at committees, that things were signed off on very quickly, and people who needed to provide advice to assist us in setting this up provided advice very promptly. We've had very motivated ID registrars, Sam being absolutely key to that, and we've had a very enthusiastic pharmacist team, which I just think shows you can do quite a lot with very little. So what are the advantages of being regional? So the first advantage I found was that I knew most of my colleagues, and that's very helpful because when you're trying to set up really a change of practice at your health service, you can't do it on your own, really. You need to involve subject matter experts. And because I know most of my colleagues, I was able to identify pretty quickly which CNEs were the right people to talk to, which people I could rely on the AMS subcommittee that would help me with this. So because of that, I was able to put something together pretty quickly. Nurses were able to review it very quickly and give me the feedback about what would be possible in Albury and what wouldn't be possible in Albury. Because the procedure that I adapted originally from the Austin is, there's similarities obviously, but there's quite a lot of differences because we don't have, an antibiotic allergy team, for example. Additionally, there's a real determination in the regional centres to give the kind of care that you can give to patients in the cities here in the regions. And because of that, I didn't really encounter roadblocks in approvals, which I think has been an issue for other people at other sites from what I've heard. So there's definitely some advantages of being regional, setting up the program. And then using the procedure, most of my colleagues know me, or at least another member of my research team. And that's an advantage because in the rare cases that someone picks up the procedure and wants to do something, but that does feel a bit unsure about it, they immediately know who they can contact. So there's less barriers to setting up the procedure and less barriers to using the procedure, I think simply because everyone in the hospital is quite approachable with one another. So what's been the impact of our procedure? I think Albury Wodonga Health's probably been key for 2 specific parts of the oral challenge journey in Australia. So the first one was really, I believe that we were the first regional site in Australia to have sort of a widespread oral challenge procedure. And if I'm wrong, I'm happy to be proven wrong. If we're not the first, we're one of the first. But we originally provided evidence that you could safely conduct direct oral challenges in a regional centre. And our reaction rate is right in line with what you would expect nationally. And now I think what we've kind of evolved to is starting to provide some evidence that oral challenges can be conducted safely by staff who don't have specific antibiotic allergy training, as long as they have a very clear procedure that they can follow and staff they can contact if they need to. And as you can see, so we've now had 7 of our challenges completely coordinated outside of our research team, and there's probably been 5 of those this year. So that number is growing almost faster than the actual research team numbers at the moment. And of the 2 patients that had a reaction to their challenge, they weren't conducted by non-research team members. They were both research team member challenges. So obviously the data is low for the moment, but early indications suggest that non-allergy trained research team members, people who are not part of the research team who don't have allergy training can do this safely. So what's been my learnings? Don't try and do it alone. It's not that it's not possible, it's just that it's quite stressful. My favorite example was I once read in the patient notes I don't work Thursdays. I'm at home with my son on Thursdays, and there was a note from Thursday from the med reg saying, let's challenge the patient on Friday because Geoff's back at work on Friday. That was the point when I really realized I absolutely needed to involve more people. So it is possible for clinicians without training to do this. Patients really appreciate it. That's probably the reason why I'm so passionate about doing it at the moment, is that the patients are absolutely grateful that you've offered this complimentary service while they're in hospital, generally for a completely different reason. And my final learning is just that there's a lot more resources to do this in 2025 versus 2021. So when I first went through this, really the only resource was going to the sort of Centre of Excellence with the Austin and taking their procedure and adapting it. But now in 2025, there's the Safer Care Victoria Check Again network with Misha and other people who are excellent and very supportive. And there's also the NANAP, or the International Network of Antibiotic Allergy Nations, of Elise Mitri, and she's excellent as well. So if you aren't already doing this and you are interested in doing this, it's never really been easier to get the information you need to appropriate to your site. And I encourage you to do so. And Sam is going to speak now.
Thanks, Geoff. So just a few reflections really on time spent doing assessments and challenges at regional centres and at metropolitan centres. So I worked with Geoff in 2022 at Albury, but I've also worked at Austin and Royal Melbourne doing some of these challenges. I guess again, to highlight, as Geoff was saying, he really was starting a program with no local allergy expertise and no prior procedure on site, and that meant no familiarity among the staff. So the setup prior to implementing the program was obviously very crucially important. As Geoff highlighted, I think when setting up a program like this, having trusted staff like himself, who really most of the nurses on the ward, most of the ward staff knew and were able to contact, is really important. And you do need to be very hands-on at the start. So being contactable and taking responsibility for the challenges is important, both when starting a program like this in a smaller centre, and it still is important at bigger centres as well, making sure that nurses have a way to directly contact you if they have concerns during a challenge. With time, you need to balance this with the time that it requires to perform a challenge, and as staff become more confident, there is a gradual transition to becoming somewhat more hands-off in the challenge. We certainly noticed that educating staff and ourselves was really important. Uncertainty or nervousness from either the staff who are challenging or ourselves is a bad thing in a challenge. It bleeds into the patient's experience as well. And obviously, Jason mentioned a lot of the clinical benefits, but to performing a delabelling, but the patient experience of being delabeled is just as important. As Geoff mentioned, patients are extremely grateful for being delabeled and for undergoing the challenge in a safe way. And so if you're nervous and you're fearful about causing reactions, that often bleeds into their experience of the challenge. As Geoff mentioned, there were a couple of reactions, and I think particularly when setting up a program early on, it's very easy to feel guilty and responsible for triggering reactions, even if, as those reactions were very low risk allergy histories and appropriate to challenge. But even a positive challenge has its own benefits in terms of delineating for someone what they are truly allergic to and how to manage a reaction. So obviously, it's not a great thing to cause a reaction, but it does have inherently its own benefits. Conversely to that, practicing in a centre where this sort of program has been set up for a longer period makes it feel a lot more like a well-oiled machine, and there's a lot more staff buy-in. So certainly challenges that I performed more recently, you simply bring up the idea and really it just flows from there, the ward staff really going about it on their own mechanisms with more comfort in the pathway. Geoff, I might get you to move to the next slide if that's okay. Yep. As Geoff mentioned, there were a few ways that we identified patients early on. A lot of that came down to stewardship ward rounds, which without an electronic medical record really meant Geoff walking around the wards and looking at drug charts. Being linked into an ID service is really important for getting those referrals. Referrals from surgical teams about how to manage an infection when a label is present is obviously an easy way to get a challenge done. And then really the other mechanism that we used was under-resourced pharmacists. And again, without electronic medical record, that meant people doing medication reconciliations often several days into an admission where the benefit has decreased from when they're first in. Conversely to that, in a bigger centre, an EMR obviously allows much more rapid identification of allergy labels if the system is in place to allow a search for that. But it still does need a careful clinical assessment, as there's often imperfect documentation. Certainly in some of the systems I've worked, you'll see a label that is penicillin unknown, and it often leads to time-poor clinicians simply avoiding all beta-lactams and not leading to a great outcome. One of the other challenges we noticed with the paper record was accidental challenges, wherein a patient presents to emergency and it's not immediately clear that there is a label of penicillin reaction in the past, and they're given an intravenous formulation of a penicillin without having realized that. And during the period that we've challenged, there were no significant adverse effects as a result of that, but it's certainly not an optimal way to challenge. The other hazard we ran into is labels that continue to persist. It may be that a patient presents to ED and their paper record from the challenge is not immediately apparent, and so immediately that label appears right back on their file. So an EMR does help negate that, but it is a challenge that we struggled with. So Geoff, I might get you to move on to the next slide. So again, these challenges are extremely satisfying for patients, and you get a lot of gratitude for patients. And so we were just going to present a quick case of the first patient we challenged. This is a 56-year-old male who presented in 2022 with 3 weeks of fevers and drenching sweats after a dental procedure and reported a history of a childhood rash to a penicillin. Shortly after admission, his blood cultures flagged positive for a gram-positive coccus resembling strep or enterococcus. And in lieu of this reaction, he was put on kepazole and vancomycin and planned for workup for possible endocarditis. He was our first patient to undergo a direct oral challenge and underwent an amoxicillin challenge with, I think, Geoff and I sitting very closely by the bedside. Unfortunately, did not have a reaction. He grew streptomyces in his blood cultures and a toe confirmed mitral valve endocarditis. He was changed to ampicillin and underwent cardiothoracic surgery and a course of antibiotics with a really good outcome. Unfortunately, still has not had a reaction to penicillin. So Geoff, I'll get you to play the video of the patient's experience, if that's okay. Geoff, I think you might need to unmute your mic, not coming through. Geoff, do you want to try unmuting your mic to see if that gets the sound? Geoff, I can't hear it on this end.
Just a little technical difficulty there. I can't unmute Geoff on this end. Geoff, if you're able to unmute, we might be able to hear the sound. It's just not projecting through.
Serious it was. So, and then they give me the paperwork to read over and have a good think about.
Sorry, guys, just quickly, have you missed all of that because I was on mute?
Yeah.
Yeah.
Sorry, team.
No, all good. We'll just restart.
We're both here to tell you, or Gavin mainly, about his journey down the path to delabelling penicillin. I guess that's what we've heard pretty much of. Changed our lives of not worrying about this penicillin allergy. He's a pretty strong man because he wasn't in a good way when he, did it, and it was the best thing he decided to do. And once I arrived at Albury Hospital, I had an infection from a tooth extraction.
and it wasn't great, apparently. I had all sorts of stuff going on. But once I got in there and I had the infectious disease doctors, they sort of come in and asked me about my allergy to penicillin. And I really didn't know a lot in terms of Mum sort of said from an early age that I was allergic to it. And that's why I got the red dot next to my name in the medical terms. When they were explaining it to me, they could sort of tell when the medical jargon was just going straight over my head. So they backed up and put it in layman's terms, which helped a hell of a lot. So, and then they give me the paperwork to read over and have a good think about it. They give me enough time for myself, on my own, to sort of get through it, read it a couple of times to make sure that I still got it and understood. And the positives, obviously, and the risks that are associated. So you always have that, that little bit of apprehension. And, it's the way things were then. For me, I felt that if anything was going to happen, it was going to be minor anyway. So, bang, let's do it. Let's go. Lowest dose. Well, look, the transition and the delabelling, it's basically saved me life. It's obviously, as I said before, it's sped up what needed to be done before I had surgery anyway. So,
Don't be afraid to ask questions. And
that's the key, because you do, as I said, you get inundated with information and it can be a little bit overbearing and you're trying to process it all. But
it's a positive.
But in the end,
it's been a long journey, but worth it.
The outcome's good. As I said, I'm here, we're chatting. Yeah. The sun's out up here, so it's grouse.
He's even mowing the lawns.
Yeah. Just enjoying you guys. You were fantastic, everybody. Trust me, you were brilliant. And thank you for letting us speak, really. I didn't think of it as a big deal, to be honest, but there you go. Thank you very much.
I'm all right. And that's what you've done. You've given me my husband back and as I said, a father and hopefully soon a grandfather. Bye. Bye.
Gets a bit carried away at the end. That's the end of our slides, so we'll pass back over to the moderators.
Awesome. Thanks so much, Geoff and Sam. We really can't get better endorsement than what you received from Gavin and Michelle. And so thank them as well if you're still in touch with them for their perspectives today. Encourage everyone to pop questions and comments in the chat, but I might start with some while people are getting their thoughts together. Geoff, if I can start with you, you talked about how direct oral challenge in Albury is moving away from your carefully curated research setting and your trained pharmacists to non-research team members. And then Sam also talked about, that risk of accidental challenge. Can you talk a little bit about how you're navigating that, whether it's set and forget with this, well-resourced protocol and tools, whether it's something that you're having to do a lot of work in services and education so that everyone's actually then educated in doing this and then it rolls out. Can you talk a bit about navigating that? It always terrifies us when we find those kind of non-allergy-led challenges on the ward.
Yeah, for sure. So I guess the first thing I should say is when the challenges are conducted outside of the research team, they still are often people who are in contact with the AMS ID team. So probably 6 of those 7 challenges that happened outside of the research team, at the very least, either myself or one of the doctors in the office had received a phone call and or it's a patient that we talked about in AMS who was in Wodonga that we couldn't reach, and we sort of said, look, this patient should have a challenge. Here's the procedure. If you have any questions, feel free to contact us. There's only really one, I think, that sort of I found out that someone had searched the procedure on prompt and done all the work themselves. So we do still have some oversight. It's more just that I guess the work is not falling solely to us. So we can sort of just guide them to the procedure on the protocol and tell them to contact us. I guess I'm not, this is probably not the lesson we should learn from the accidental challenges, but Sam and I probably noticed, you know, I don't know, Sam, 6, 7, 8 accidental challenges the year that Sam was at the hospital. And that's just the ones we found out about. So I suspect this happens a lot. And I guess, you know, thankfully, none of those sort of accidental challenges led to reactions, which I suppose maybe gave me some confidence that in patients that at least have the assessment first to show their allergy label is low, their true risk is low for a true reaction, that those patients probably could have their allergy label challenged by people using our protocol without sort of direct AMS ID oversight. So yeah, so to answer your question, yes, we're still involved. We're just not doing the hard work, I guess.
Kind of, yeah, decentralized model. No, that's awesome. And it leads to a question that's in the chat from Jennifer Eels, who says, I work in a small residential aged care facility in regional remote Vic, and I'd love to implement and offer this to our residents who have pen allergies, but how might you advise we approach this without an on-site pharmacist or GP, which is an excellent question. Thanks, Jeff.
Yeah, that's a really good question. I think it would be possible. My advice, I'd probably have 2 bits of advice. The first one would be I'm trying to think of the site, Jason, you'll probably know it. I think is it Jacqueline is that right? Do you want to jump in?
Yep.
Yeah, so they've implemented something or attempted to implement something where they basically just have GPs come to the health service. So in essence, it would be kind of similar in that their hospital doesn't have a physician on site. And they've tried to time challenges when the GP visits, I believe. I think you could definitely do it. I think if they had some sort of committee oversight and were able to implement an approved procedure, you could do, so nurses could still conduct an allergy assessment, or the GP could conduct an allergy assessment 1 week, and then the challenge could be given the following week when the GP comes back. There would be ways that it can be managed. If you want to email me, I've got my email on the slides. I'm more than happy to talk about it in greater depth. But I do think it would be possible. It would be more difficult, though, for sure.
The other point to add to that, Jeff's 100% right, is that we're seeing a lot of infection control practitioner-run models coming out in rural remote settings. A lot of nurse-run, single ward, even urgent care adjacent facilities. So I'd also encourage you to join the Check Again program, because we can link you in with other hospitals that have got a similar process happening. So yeah, definitely can be done.
Fantastic. Jump to Karen Thursky with a hand up. Kaz.
Hello, everyone. I'm back from 12 weeks sabbatical where I was in Europe and North America, and I can hand on heart say that some of the work that Jason's doing, embedding this into routine clinical care, is really still very novel and innovative. And I didn't see these sorts of programs in some of the very largest and most famous hospitals in the US. So congratulations. My comments relate to surgical antimicrobial use, Jace, and one of the issues is this trying to go in with a single sort of intervention. We know that with the SNAPS data overarching across all craft groups, inappropriateness for various metrics sits around 50% across all craft groups. So it's clear that there's multiple touch points where we need to be influencing prescribing, almost like a surgical bundle. It is one of the key outputs of RADAR, which is our new CRE kicking off this year, where we're going to be looking at optimizing surgical antimicrobial use. And I just wonder what your thoughts are here. And the second half of the question, which is no surprise coming from me, is, one of our biggest challenges is how to effectively digitalize our care. Yeah. When we've got these great applications that have been user-centered design, obviously there's always room for improvement,
Yeah.
But we're somehow caught in this bind where we have big EMRs where their mode of operation is to not to integrate. Even though interoperability in terms of transitioning patients in and out of the community is really a major, really actually essential if we're going to sort of do this properly. So 2 halves of the question, Jace.
Great. First one, completely agree. I think what we've found is that allergy is a Trojan horse, actually. And a lot of our AMS interventions have nothing to do with the allergy assessment or the challenges, actually bringing AMS to the table. And we saw that with our first allergy outpatient clinic, where providing the recommendation letter to patients almost forced the clinician into prescribing. And then now with our round, which Gemma does every Wednesday, most of the interventions are an AMS intervention outside of the allergy. So I think it's a great opportunity to bundle other things on. And I think you inadvertently get it because you get them. We can also add in, give the dose 30 to 60 minutes beforehand. Don't use post-op. You could add those recommendations into that bundle quite easily. And I think your uptake would be greater because we're not coming in with a negative slant. A lot of the time I find when we do AMS interventions, I know this damn word police, but allergy's been good because we're kind of giving something back. It's a positive interaction with the clinician, so we can leverage that. So first question, 100% agree. That could be the way forward. Second one, also agree. We've had enormous trouble trying to integrate this into custom-built solutions, both in Cerner and in Epic. Like, we've done them, but they've not been what we've wanted. Bidirectional flow with standalone apps is frowned upon, even though the capability for it is there, both from the vendor and from the hospital. I'm being very frank here, but that's okay. So we found it really troublesome. We're hoping we can leverage some MRFF grants moving forward to really workshop these ideas. We've spoken to you about that with CAS and the Centre for Digital Health, and then move them forward, because our EMR is never going to be able to deliver all of these solutions, and we have to find ways to be able to integrate these third-party endorsed solutions that have gone through a lot of consumer, both clinician and patient work that the EMR hasn't. So now I'm ranting. So yes, completely agree. And I hope in the next few years we can do this. There's too much good value going into these data points to not be then visible in the EMR and come out as well. Anyway, shut up, Jason.
One thing that is really, really interesting, anyone who follows us on LinkedIn, and it's worthwhile because we will repost or highlight key digital health and AI papers that are coming through. And I think that there is actually an ethical, moral obligation to do this. And one of the challenges has been this, there was a great paper coming out of CRD saying, why are infectious diseases being gaslit? And it's a fascinating view. It's an American paper, and the opening statement is around, a request from ID to have something put into the EMR. And the comment back from EMR is, thank you. At the moment, this is not a priority. We're doing a major upgrade. We'll look at it in 6 or 12 months. We've actually heard those words ourselves. And so I agree with you, Jace, because when highly specialised workflows are relevant and effective, and we're up against a generic approach. Now, I think that the pendulum is swinging now, where there is a recognition that highly specialised workflows are relevant and important. The interesting point is that we're often asked to make a business case for return on investment, but you never see anyone actually do the return on investment work. So it's like a loose way of delaying something by saying, well, what's a return on investment? And the discussion with the quality and safety people is that we need to make the case about, infections avoided, or, look at it in a completely different ways as opposed to return on investment. So we actually need to be better in how we're actually developing our programs and embedding them into care. I'm on a rant too now. Sorry.
No, it's super useful discussion and lovely to see Kaz and JT debate these topics because it's incredibly important. It's things we're thinking about every week. We are at time though, so I will draw this meeting to a close. There was an update about Gavin in the chat. A very pertinent question was whether Gavin's heart infection was due to a complication of having an antibiotic allergy and inappropriate antibiotics, which has been answered by Sam with thanks. I'd very much like to thank our speakers for joining for that really interesting and fruitful discussion about all things allergy related. I'm going to go do the allergy round at the Austin with the wonderful Elise Mitru now, and wishing everyone a lovely Wednesday. Recording will be available on the NCAS website after this. And our session next month is on environmental antimicrobial resistance and antimicrobial stewardship. So thanks very much to all our speakers, panelists, and to NCAS.
Thanks for having us.
Guys.